Hello everyone, I'm Sandeep, internal medicine resident at St. Vincent Hospital, Worcester. Here I present my case allergic to periods. Progesterone hypersensitivity typically causes a skin reaction that usually begins 3 to 10 days before menses and resolves afterwards. The exact cause of progesterone hypersensitivity is unknown, but exposure to external sources of progesterone such as oral contraceptive or drug used for fertility treatment have been implicated. There have been no observed spontaneous resolution of autoimmune progesterone dermatitis in the absence of either some therapeutic intervention or natural menopause. Our patient is a 27-year-old female with a history of childhood seizure disorder who developed urticaria in the 6th month of her first pregnancy. Since then, she's had persistent symptoms with diffuse erythematous, pruritic, non-tender lesions in close relation to her menstrual cycle. She was started on prednisone with improvement and subsequently transitioned to omalizumab. She was started on an anti-IgE medication even without a positive skin test, as she fit 2 out of 3 diagnostic criteria for autoimmune progesterone dermatitis as proposed by Warren et al. However, she continued to have mild urticaria related to her periods. She presented to the hospital with hives for a day and a sensation of throat closing. This was accompanied by syncopal episode and a panic attack. On presentation, she was hemodynamically stable except for a heart rate of 114 beats per minute. There was no stridor or respiratory distress. A diffuse urticarial rash was present, similar to the picture shown here. Laboratory data was significant for leukocytosis of 15,000. COVID testing was negative. Functional C1 esterase inhibitor was more than 91. She had a negative rapid throat streptococcal test. Further inquiry revealed that over the last 2 months, she had been victim of a sexual assault resulting in pregnancy, for which she underwent an abortion at 3 weeks of gestation with subsequent implantation of copper IUD. Given this traumatic event, she missed a dose of omalizumab 1 month prior to presentation. While in the hospital, she was treated with IM epinephrine, IV dexamethasone, and IV famotidine. Her symptoms improved and she was discharged on tapering doses of prednisone along with her home omalizumab. Currently, she is symptom-free on her regular omalizumab treatment. There have been about 200 cases of progesterone hypersensitivity, but the exact number is difficult to estimate, as some may go undiagnosed, misdiagnosed, and others may not seek medical attention. Skin symptoms may include rash, swelling, itching, hives, and red flaky patches. More severe symptoms can include open sores, wheezing, and an asthma-like reaction. Usually treatment consists of anti-allergy like steroids or anti-IgE therapy like omalizumab dosed according to IgE levels, or inhibiting progesterone secretion by suppressing ovulation or with definitive treatment including oophorectomy, depending on the patient's future needs. Our patient was treated with standing doses of omalizumab and, despite that, continued to be symptomatic. There are many triggers for an attack. In this case, we believe symptoms occurred as a result of increased hypersensitivity to endogenous progesterone, triggered immediately after medical abortion. Further studies are needed to better ascertain the prevalence of progesterone hypersensitivity, other factors which affect the symptoms, and the effect of pregnancy on these symptoms. Thank you.